All right, guys. My name is Dhaliwal. I'm one of the anesthesia critical care attendings here at UK, and today our ITE review is going to focus on the kidneys. To start out with, the kidneys receive about 20% of the cardiac output delivered from the heart, despite the fact that they contribute less than 1% of our total body weight, right? Um, and the renal blood flow is typically maintained due to autoregulation, so it's maintained across a wide variety of arterial pressures. GFR is also maintained across a wide variety of pressures, right? GFR is your glomerular filtration rate, and it's roughly about 125 milliliters per minute, and it is dependent on a couple things, right? Your glomerular filtration pressure, which turns out to be a function of your renal arterial pressure, your afferent and efferent arterial or tone, right? So the afferent arterioles are going to the kidneys, and the efferent arterioles are the arterioles that leave the kidney. And we know different medications can cause vasodilation and vasoconstriction of these vessels, and can lead to alterations in perfusion pressure for the kidney and overall kidney function. Things that we think about are things like NSAIDs, as well as ACE inhibitors. The first keyword that we have is the Renin-Angiotensin-Aldosterone system, right? This is a hormone system that helps us regulate blood pressure, fluids, and electrolytes, as well as overall systemic vascular resistance. It plays a big role, and all those in the kidneys also play a big role, right? So renin, it's an enzyme that's secreted by your juxtaglomerular apparatus in response to several things. Increase in sympathetic tone, a decrease in renal perfusion pressure, or a decrease in sodium delivery to your distal convoluted tubules. Renin would then work on angiotensinogen and convert it to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 in the lungs by ACE converting enzyme. Ang2 has several properties, right? It increases the efferent arteriolar tone at lower levels, and it can constrict the afferent arteriolar tone at higher levels, right? It also leads to the stimulation of aldosterone, which will then increase the reabsorption of water and sodium. So the overall net effect is vasoconstriction, an increase in water and sodium retention. Here is the renin-angiotensin-aldosterone system in schematic form. So on the left, you see an increase in sympathetic tone, decrease in blood pressure, or a decrease in sodium delivery to that distal convoluted tubule will lead the kidney to release renin, which then converts angiotensinogen to angiotensin 1, which is then converted in the lungs by ACE converting enzyme to angiotensin 2, which is a primary modulator of the renin-angiotensin-aldosterone system. Ang2 directly will lead to the increase in aldosterone, which then increases volume retention, water retention, and sodium retention. So overall will increase your blood volume and probably your cardiac output from that way. Angiotensin 2 also directly leads to an increase in systemic vascular resistance, which will increase your blood pressure. Classically, we have drugs to modulate this hormonal system overall. ACE inhibitors, lisinopril for example, work by inhibiting ACE, so it inhibits angiotensin 1 to be converted to angiotensin 2. We also have ARBs, which directly block angiotensin 2 receptors, so it causes a decrease in your increase in SVR. More recently, we've actually been using angiotensin 2 directly as a newer vasopressor. So directly infusing angiotensin 2 into patients will increase their SVR overall, which makes sense. We understand that the kidneys are very important in maintaining homeostasis that we talked about earlier, right? So we have to have a way to measure how well the kidneys are functioning or how poorly they're functioning. The most common method is the serum creatinine, right? We use this as a marker or a surrogate for GFR. It is produced by the skeletal muscle and then excreted by the kidney. So the serum creatinine that we measure reflects the balance between that production and excretion. It isn't an ideal test. Number one, because it's influenced by skeletal muscle mass, right? So someone who is very muscle bound, like Bjorn, probably has a higher creatinine than somebody who might have a little less muscle. You also don't get a rise in your creatinine until your GFR has declined by roughly about 50%, right? So you can imagine an elderly person, little old lady, who probably does not have much skeletal muscle mass, might have a normal looking creatinine by the lab test, but her GFR will actually be decreased by that point. Blood urea nitrogen, or BUN, is another method that we use to gauge kidney function. It is also affected by a couple exogenous things like how much protein we take in, right? And it also, people that have GI bleeds tend to have a higher BUN as well. So keep that in mind if you see a spuriously increased BUN. We usually look at that BUN to creatinine ratio as a marker of kidney dysfunction. The higher that number, typically greater than 20, is when we start to think that the patient might be experiencing what we call a pre-renal state, or might be hypovolemic. Two other commonly used tests to look at kidney function are creatinine clearance and FeNA, or fractional excretion of sodium, right? So for creatinine clearance, it is a marker or a measurement of your glomeruli ability to excrete that creatinine into the urine. We already learned that creatinine comes from skeletal muscle and is excreted into the urine by your kidneys. So this is a marker looking at how well your kidneys are able to put that creatinine into urine, right? The downside of this test is that you need to collect a significant amount of urine over time. Often it's done for 24 hours. So you have to collect the urine and then send it to the lab for testing. Your fractional excretion of sodium is an assessment of how much sodium is being excreted into the urine, right? So if the FeNA is low, it's an indication that the kidneys are functionally able to reabsorb sodium, and also that there's a physiological stimulus to hold on to sodium, right? So imagine a pre-renal or hypovolemic state. So if the FeNA is high, then it's an indication that there is some sort of intrinsic problem with the kidneys, something like ATN or AIN or something along those lines, because they are not able to reabsorb sodium, if that makes sense. So Stafford ATN and Oliguria differential diagnosis is basically a differential diagnosis for acute kidney injury. And so we should go about figuring out the differential the same way as we would for any kidney injury, right? You start with the pre-renal causes of AKI, and the ones we think about most commonly is hypovolemic, right? The person's dehydrated. But it's not just hypovolemia, it's shock of any kind, right? Hypovolemic shock, hemorrhagic shock, cardiogenic shock, right? So you have decreased blood flow to the kidney itself. Abdominal compartment syndrome is a cause of pre-renal AKI as well, as the overall perfusion pressure of that kidney goes down, right? And same thing for congestive nephropathy. So you imagine somebody that has very high venous pressures, RV failure, high ascites, that perfusion pressure to the kidney is low. So that is what we would classify as pre-renal or underperfused. Direct injury to the kidneys, nephrotoxic agents, radiocontrast, which we'll talk about in a second, but antibiotics, specifically your aminoglycosides, vancomycin, and amphotericin can lead to direct kidney injury. NSAIDs and ACE inhibitors work can injure your kidneys by vasodilating those efferent arterioles that we saw earlier. And then post-renal causes basically anywhere along the tract, right? So oftentimes we think about stones and cancer or prostate hypertrophy causing post-renal issues. Surgery specific, cardiopulmonary bypass is a big culprit, but any large non-cardiac surgery can also lead to postoperative oliguria and AKI. Aortic cross clamp is one as well. And then patient-specific problems, things like burns, right? And then just sepsis and critical illness in general can lead to oliguria postoperatively. Contrast-induced nephropathy is a little controversial, but let's talk about it because it is still going to pop up on your boards and still a keyword. So your risk factors are folks that have diabetes, that have pre-existing kidney disease, and then older folks as well, right? How does it work? I think it's a direct nephrotoxin, and also the contrast will lead to the secretion of vasopressin, which leads to the activation of that Renin-Angiotensin-Aldosterone system, which can lead to AKI that way. How do we go about mitigating the risk of contrast nephropathy? So avoiding giving it in the first place is what we typically do, but there's been a lot of studies with N-acetylcysteine and sodium bicarb. Volume expansion in general is also one way that you can prevent contrast nephropathy, at least according to what the books say, right? But there have been many, many studies looking at contrast nephropathy, and every study that's been done, there's been no evidence that it increases the risk of dialysis. Because what are we truly worried about, right? Are we worried that the creatinine goes up from, 0.8 to 1.2? Not really. You're worried about, killing the kidneys in general. So there's been no evidence that contrast increases the risk of dialysis. That being said, we still avoid contrast pretty frequently in anybody that has, CKD, because we're scared we're going to tip them over the edge. But more data is going to come out, hopefully. I think the stance that we take oftentimes is if the patient needs the contrast, regardless of what their kidney function is, they should receive the contrasted studies. So, a little bit confusing. This still pops up on your boards. N-acetylcysteine, bicarb, maybe they're helpful, but probably not. So now let's move on to end-stage renal disease. The kidneys have died at this point, and they can pose some physiologic and pharmacologic challenges in the operating room, right? When you bring these folks back, oftentimes they have long-standing histories of high blood pressure and diabetes, and so dealing with all the sequelae of that can be complicated. They often have a normocytic anemia as well due to the decreased erythropoiesis. So oftentimes you'll see that darbepoetin is part of their medical regimen. Apart from the anemia, they also have some platelet dysfunction due to uremia at times. So DDAVP is often given to folks with end-stage renal disease when they're seen as being a little bit oozy, right? What about succinylcholine? Is that an okay medicine to give to anybody that has end-stage renal disease? Yes, it is, right? So we know that it'll increase your potassium a little bit. Roughly, it's about half a milliequivalent per liter. This says 0.6, that's fine. But it's probably going to be the exact same in somebody with end-stage renal disease. They might increase a little bit. So, you'll usually have labs on these people, right? So it's okay to give them succinylcholine. If they're potassium 7.5, it might not be the best idea to give them succinylcholine, right? But honestly, these folks can better tolerate hyperkalemia than you or me. And what about LR? Sometimes people want to avoid LR in these patients because it also has potassium, but we've seen that actually people that receive normal saline probably have worse acidosis and hyperkalemia as compared to lactated ringers in end-stage renal cases. From a neuromuscular blockade standpoint, cisatracurium is probably the one most often used because it undergoes Hoffman degradation, right? It does not rely on the kidneys or the liver for clearance. Rocuronium and vecuronium are okay. You just have to understand that the half-life might be a little bit increased, mainly due to the increased volume of distribution. Roc is cleared mainly unchanged in your bile, but will get renally excreted a little bit. And so it's probably okay for single doses and even kind of repeated doses, but you just don't want to kind of have repeated large doses or long infusions of Roc and Vec, because then that might lead to increased time of paralytic function, right? But single doses, couple doses is probably okay. From your reversal, your anticholinesterase, I know some folks don't even use these anymore, but neostigmine, your anticholinesterase, is the one we most often use, and it does undergo about 50% clearance from the kidneys. So there is reduced clearance with folks with end-stage renal disease, but typically you don't really need to adjust the dose much, especially when you give it with like glyco or something along those lines. An antimuscarinic, you're unlikely to get that recurarization, the patient getting paralyzed after the neostigmine wears off, though. That's unlikely to happen in someone with end-stage renal disease. After your kidneys die, humans have figured out a way to do the job of the kidneys for you, right? This renal replacement therapy. The one we think about most commonly is hemodialysis or intermittent hemodialysis. That's when folks kind of go on an outpatient basis a couple times a week to get their dialysis, right? And it kind of helps support the kidneys maintain that homeostasis from an electrolyte, volume, and pH standpoint. There's two main flavors, right? Diffusion and convection. Diffusion is the one that we'll see used with the intermittent hemodialysis, the one that people go a couple times a week. It has very high flow rates, and what happens is you have solutes. You have your blood that flows in one direction and dialysate that flows in an opposite direction. And these solutes from your blood travel down a concentration gradient across the semi-permeable membrane, right? And that's what we see with intermittent HD as well as CVVH, and what you see there is SLED, which is slow, low efficiency dialysis. Convection, on the other hand, is what we do typically in the ICU, that RRT, CVVH, and it's basically just hydrostatic pressure, which kind of pushes fluid out of the blood. And then you also get solute drag along those, along that as well. So probably not as efficient at getting rid of electrolytes and things, but still very good at ultrafiltrating, which is also very important. Moving on to pharmacology, we'll start with dopamine, a inotropic oppressor that's fallen out of favor in the last several years. Classically used quite a bit in numerous different indications, right? It works by hitting a couple different receptors, right? And you can think about it at low, medium, and high ranges, right? The low range is kind of that 1 to 3 mics per kilo per minute, and it hits the D1 receptors, right, on your kidneys, and it works to increase that afferent arterial tone, or decrease the tone, so it vasodilates it. It might promote some natriuresis and increase your GFR, right? The classic thinking is that this would somehow protect your kidneys, but numerous studies have shown that renally dosed dopamine, low dose dopamine, does not decrease the chance of an AKI or somebody going on to dialysis, right? We'll often see it used here at our institution as an adjunct to diuresis, right? If you want to use it as to help someone keep peeing, then you might see somebody on 1 or 2 or 3 of dopamine, but it does not improve outcomes for kidneys at all. For your middle doses, anywhere between 2 to 5 to 8 to 10, right, up to 10, you kind of get those beta effects, right? That's where you get your inotropic support, increases the heart contractility, and chronotropy as well. And then higher doses, above 10 to 20, etc., that's when you get a lot of your alpha and just pure vasoconstriction. Dopamine has been associated with a significant amount of arrhythmias, probably more so than any other pressor inotrope, except for maybe epinephrine, right? Phenoldiazepam also is a very selective D1 agonist, and it is a vasodilator that we use mainly for kind of hypertensive emergencies. Similar to low-dose dopamine, it might increase your renal blood flow and help with diuresis. The dosing of it is, pretty low, 0.2 mics per kilo per minute up to 0.5 or to 0.8 mics per kilo per minute. Kind of has a longer half-life than something compared to like nicardipine, so it's not used a ton, right? But just know that is a selective D1 agonist. Understanding how diuretics work is pretty important up in the ICU, but even in the operating room, you're going to have patients that come to you on these medications, and you'll need to understand the side effects and mechanisms of actions of them, right? So your thiazide diuretics, you'll see people on pretty regularly, mainly hydrochlorothiazide. It's a very old and effective medicine at lowering your blood pressure, right? The other ones that you see there, metolazone, chlorthalidone, chlorothiazide, are also thiazide diuretics, and they work mainly at the distal convoluted tubule to decrease the reabsorption of sodium and chloride, right? This can actually also lead to an increase in calcium, right? Which is different than the loop diuretics, which you see up there, which will induce hypocalcemia. Your loop diuretics are going to be the mainstay of what we use in our units and in the ORs to force diuresis on patients, right? They work at the loop of Henle, loop diuretics, right? And inhibit the reabsorption of sodium chloride and also cause hypokalemia as well, right? When you use the two together, a loop diuretic and a thiazide diuretic, they can work synergistically to get more bang for your buck in diuresing a patient, right? So if you combine them, you get a pretty nice diuretic response. Mannitol, sorbitol as well, are two osmotic diuretics that we use frequently in the neurosurgical ORs as well as our neuro ICUs, right? They work on the proximal loop of Henle's and they also inhibit sodium and water reabsorption. You just need to be careful in folks that have, say, congestive heart failure or something like that, because they can actually initially lead to an increase in volume expansion, but after a while you can get pretty hypovolemic just because they're pretty impressive diuretics, right? And then finally, acetylzolamide is a carbonic anhydrase inhibitor, which works to decrease your bicarbonate reabsorption, right? So it alkalizes the urine and induces a metabolic acidosis. We use this as an adjunct to kind of aggressive diuresis. When we over diurese someone or just aggressively diurese someone, they can become pretty metabolically alkalotic, right? It's iatrogenic. We induced it, so the way we fix that is by giving a carbonic anhydrase inhibitor to get rid of that bicarb. The carbonic anhydrase inhibitors can also lead to some hyponatremia as well as hypokalemia, and they work on the proximal tubules. Here's a really good chart that kind of summarizes the different diuretics that we use in critical care. This is from the Internet Book of Critical Care. It's a great resource that you guys should check out. The ones we didn't talk about on the previous slide are your potassium-sparing diuretics like spironolactone and amiloride. They both will end up increasing your potassium as opposed to all the other diuretics that we use. Oftentimes they are used in cirrhotics and heart failure patients. And then also we can use spironolactone in people that have pretty refractory hypertension as well. But check this slide out. It's very useful to kind of answer any questions on the diuretics that we use frequently. And here is a great slide that kind of shows you the different parts of the nephron where the diuretics work, right? So acetazolamide, kind of number one there, the proximal convoluted tubule. Your osmotic agents also work there as well, mannitol, sorbitol, your loop diuretics at the loop of Henle, your thiazides, your aldosterone antagonists at the collecting tubule, and then of course vasopressin at the collecting duct. So I'll leave that up and just check that out. It's a great slide. The final keyword in the renal section is lithotripsy. This uses electromagnetic shocks, electromagnetic waves to help break up stones that form in your urinary system, so kidney stones, ureteral stones. It is useful for these small and medium-sized stones, but not as good for larger ones. And it's also not especially good for stones that are found in the lower pole of your kidney. For those, you'll probably end up needing a scope. The old school ones from decades ago used to require the patient to be immersed in a large water bath, and they'd use a spark plug thing that would kind of cause these shocks, and the waves would break up the stones. Now they kind of use these piezoelectric crystals or electromagnetic generators to produce the shock along these water-filled cones or cushions, and then so you don't have any air, so the shock waves can be just coupled to the patient that way. There's many ways to do it. You can do it general anesthesia, monitoring anesthesia care, or even regional. And then contraindications, so pregnancy is a big one. If the patient is septic, that's a big one. And then if there's any obstruction beyond where the stone is located, you don't want to do that. Triple A's, so used to be a contraindication, not so much anymore. And then you don't want the patient to be terribly coagulopathic either, right? Pacemakers are not a contraindication for this. Like anything, like any surgery, the pacemaker, you'll probably want the pacemaker to be integrated at some point recently before you go back, but pacemakers are totally fine for lithotripsy. And I just kind of wanted to show you what the old school water baths used to look like, right? These don't, I mean, they still probably exist somewhere, but we don't use them like this anymore. It's much more refined way of doing it. The patient doesn't need to be immersed in water. They can just be on a table, pretty chill. And that's really it. Okay. Thanks for taking the time. Talk again soon.